Hello everyone. Welcome to IS Pharmacology Difficult Podcast, and today we are going to do the next part of the sympathetic nervous system. We are going to cover today sympathomimetic drugs, and that is all included in the pharmacology crash course next part. So without any delay, let's get started. The sympathomimetic drugs, they actually increase the activity of the adrenergic system, and they are classified as directly acting, indirectly acting, and mixed action sympathomimetic drugs. What is the difference in all these three types of classified drugs? Let's get to know about it. The directly acting drugs, they stimulate the alpha and the beta receptors. Indirectly acting drugs increase the amount of the noradrenaline on the synapse, and mixed action sympathomimetic drugs possess both these properties. They act on alpha and beta receptors also, and they increase the quantity of noradrenaline in the synapse. Got it? Let's get further. Next, we're gonna know in detail about directly acting sympathomimetic drugs. Now, they can be again classified into catecholamines, non-catecholamines. Amongst the catecholamines also, we have further classification as endogenous and exogenous catecholamines. The endogenous catecholamines, they are naturally found, and they are adrenaline, dopamine, noradrenaline. The endogenous, these are the endogenous catecholamines. Coming over to the synthetic or the exogenous catecholamines, they are dobutamine, dopexamine, phenoldopam, and isoprenaline. So these are the exogenous or the synthetic catecholamines. And what about non-catecholamines? Non-catecholamines, they do not contain in their structure dihydroxybenzene nucleus. What is the characteristic feature of a catecholamine? The presence of dihydroxybenzene nucleus, and that is absent in non-catecholamines. What are these? The non-catecholamines, examples are xylometazoline, clonidine, phenylephrine. Then we have salbutamol. Then we have methoxamine. They are selective agonists at alpha 1, alpha 2, beta 1, and beta 2 receptors. Now let's in more detail talk about catecholamines. Adrenaline, noradrenaline, dopamine, they are very powerful compounds. They have a very high potency, but their half-life is very, very short. And why it is short? Because they are rapidly inactivated by enzymes like monoamine oxidase MAO and catecholamine O methyl transferase COMT. Okay? Now, they are polar also, and they are not very easily entering into the central nervous system because they are polar. Okay? That is another feature of these catecholamines. Now, metabolism occurs, I told you, by enzymes MAO and COMT. In the liver, it is predominantly by MAO. And because of their very short half-life and such kind of metabolism, their oral use is not preferred. They are not used orally. Okay? Now, adrenaline acts on what kind of receptors? Let's get to know about it. Alpha 1, alpha 2, beta 1, and beta 2 receptors. And noradrenaline does not have the similar kind of an activity. It has very poor beta 2 activity. So what are the receptors on which the noradrenaline mainly acts? Alpha 1, alpha 2, and beta 1. What about isoprenaline? Isoprenaline has very little alpha activity. It mainly acts upon beta 1 and beta 2 receptors. Now, there is a variety and varied effect on the heart rate and the blood pressure of all these drugs. Let's get to know about it. It's very interesting also, and very informative, and very important also. Now, two kinds of blood pressure are systolic blood pressure and diastolic blood pressure. Let's get to know the effects of all these drugs on these two kinds of blood pressures. Systolic blood pressure is, how do we know about systolic blood pressure? It is determined by the cardiac output, and diastolic blood pressure is dependent upon the state of the blood vessels. So, beta 1 action determines the systolic blood pressure, and the state of the blood vessels determines the diastolic blood pressure. If there is an excitement or stimulation of the alpha 1 receptors, it increases the diastolic blood pressure. Why? Because there is a vasoconstriction. If there is excitation or stimulation of the beta 2 receptors, that results in reduction of the diastolic blood pressure, and that is because of the result of the vasodilatation. That is very simple, nothing very complicated about these explanations. Let's get to know more. If the diastolic blood pressure increases, then the baroreceptor stimulation occurs, and there is a baroreceptor mediated release of acetylcholine. That is actually a kind of a reflex action. And due to this release of acetylcholine, the heart rate is decreased. Why? Because of the action on the M2 receptors. Now, if the diastolic blood pressure decreases, then that increases the central sympathetic outflow, and that increases the heart rate. Now, these explanations are very step by step, and they are very simple, so no need to repeat it. If you want to repeat, you can go through the recording once again. What about noradrenaline? Noradrenaline decreases the heart rate in normal terms. But if you give noradrenaline after a dose of atropine, there is a seen increase in heart rate. Why? Because the reflex action is abolished. So the heart rate only increases. There is no decrease in heart rate. That is very interesting, right? Let's get to know further. Now, have you heard about anaphylactic shock? Well, that is a very famous thing, and adrenaline is the drug of choice for anaphylactic shock. How do we give it? 0.5 ml of 1:1000 solution concentration. That is, what is the concentration? 0.5 milligram. That is given intramuscularly or subcutaneously injection. Intramuscular route is preferred on the lateral thigh, because if you prefer the subcutaneous route, there is a lot of variability in the results. So better go for intramuscular route. Now, why we avoid the intravenous route? Because it is generally avoided, but if the concentration is very low of adrenaline, say about 1:10,000, then you can opt for intravenous route. Only in that case. In no other case will you go for intravenous route. Now, adrenaline also is used to prolong the duration of action and decrease the systemic toxicity of local anesthetic agents. So it is given along with the local anesthetic agents. Now, if the patient is suffering from cardiac arrest, then adrenaline is preferred drug, and the preferred route is intravenous, and that is followed by the another routes like intraosseous and endotracheal. What about dopamine? This is all about adrenaline. Let's go to another drug, dopamine. Dopamine is the drug of choice for cardiogenic shock. And cardiogenic shock, especially when it is associated with oliguria, renal failure. How does it act? At a dose of 1 to 2 microgram per kg, it acts on the D1 receptors. At a dose of 2 to 10 microgram per kg, it acts on the beta 1 receptors. And at a higher dose, that is more than 10 microgram per kg, it acts on the alpha 1 receptors. So it has a dose dependent action. Dopamine always shows a dose dependent action. Mark my words. When it acts on the D1 receptors, it causes renal vasodilatation, it maintains the renal perfusion and the glomerular filtration rate. Other inotropic agents are noradrenaline. They cause renal vasoconstriction, and that results in worsening of the renal failure. So never use them. What about another drug? Ibopamine. Ibopamine has similar properties as dopamine, nothing much special to comment about it. Dobutamine. It is relatively selective beta-1 agonist and it has no or very nil actions on dopamine receptors. What is the function or what is the use? It increases the cardiac output and very little action is there on the heart rate. What about dopexamine? Dopexamine combines beta-2 and D1 agonistic activity, and there is also another noradrenaline reuptake inhibitory action of dopexamine. I repeat, it has an agonistic activity on beta-2 and D1 receptors and also shows noradrenaline reuptake inhibitory action. Okay? Next drug, phenoldiprem. Phenoldiprem is a D1 agonist. It is very, very useful in hypertensive emergencies. Now let's talk about non-catecholamines. First of all, I'll come to alpha-1 agonists. These drugs, they are used as nasal decongestants. The drugs are nefazoline, oxymetazoline, xylometazoline. Now, once the effect goes down, then after congestion is seen. If you use these drugs for a very long duration of time, they can result in side effects like atrophic rhinitis, and that is also known as rhinitis medicamentosa. What about phenylephrine? Phenylephrine is basically a mydriatic agent. It increases the pupil size. And it does not cause cycloplegia. These are the characteristic features of phenylephrine. Another drugs like methoxamine, mephenteramine, they increase the blood pressure, especially when a patient is suffering from hypotension. Another drug, midodrine, is basically a prodrug and its active metabolite is desglyamidodrine. And the active metabolite, that is desglyamidodrine, it is used in the treatment of orthostatic hypotension. It also increases the blood pressure. One more drug I want to talk about, phenylpropenylamine. It was used previously, now it has found to be associated with hemorrhagic stroke and it is banned. Now, alpha-2 agonists, next is what I'm going to talk about. Alpha-2 agonist drugs are clonidine and methyl-dopa. Methyl-dopa is a prodrug and they can be used for the treatment of hypertension. Increased blood pressure. So, their function is to decrease the blood pressure. Clonidine has other multi-uses also which I want to talk about, or I'll just comment in brief. It controls diarrhea in diabetic patients and also it controls diarrhea in autonomic neuropathy. It is used in the prophylaxis of migraine. It is used in the management of the withdrawal symptoms, especially of opioids, alcohol and nicotine. It can cause relief in pain if it is given epidurally in combination with opioids. It is also used as a monotherapy for the treatment of ADHD, capital ADHD. It can be used as add-on drug also for the treatment of capital ADHD. And another use is Tourette syndrome. It is used in the therapy of Tourette syndrome. Another drugs, apraclonidine, brimonidine, they are selective alpha-2 agonists and they are applied topically for the treatment of glaucoma. Another drug, dexmedetomidine, it is a central alpha-2 agonist. It is used in pre-anesthetic medication. It can also be used to sedate the patients who are intubated initially, and also to sedate the patients who are mechanically ventilated in the ICU. Another drug, lofexidine. Lofexidine is a new alpha-2 agonist. It is recently approved to decrease the opioid withdrawal symptoms. Another drugs, guanfacine and guanabens. They are also alpha 2 agonists, and they are similar to clonidine, but they are very rarely used now. Another drug, tizanidine. Tizanidine is used as a muscle relaxant. This is all about alpha 2 agonists. Let's talk about beta 1 agonist. Beta 1 agonist, pranalterol. Pranalterol is the only beta 1 agonist that is non-catecholamine. It is beta 1 selective agent, and it can be used for the prompt reversal of the beta blockade. That's all in beta 1 agonist. Let's move quickly over to beta 2 agonists. Salbutamol, that is also known as albuterol, livalbuterol, bitalterol, phenoterol, metaproterenol, terbutaline, perbuterol, salmeterol, formoterol, arformoterol, carmoterol, indacterol. These are all selective beta 2 agonists. They are like tongue twisters but quite easy to remember. All ends with terol, I guess so. And they are very useful drugs in bronchial asthma, rhydodrine and isoxsuprine. They are agonists, beta 2 agonists, but their use is different. They are used as tocolytic drugs, that is uterine relaxant agents. Let's talk about beta 3 agonists. Marabegron. Marabegron is a very new drug, beta 3 agonist. It stimulates the beta 3 receptors in the urinary bladder, and it is very useful in the treatment of overactive bladder. Next, we're going to talk about indirectly acting sympathomimetic drugs. Indirectly acting sympathomimetic drugs increase the release of noradrenaline in the synaptic cleft, or they inhibit the reuptake of noradrenaline. They enter the cytoplasm of the neuron by the same transporter which is responsible for the reuptake of noradrenaline. Then they enter the storage vesicles and they displace and release the stored noradrenaline. The released noradrenaline, it activates the adrenergic receptors, and if the dosing is repeated, then at short intervals, tachyphylaxis develops. What is tachyphylaxis? That is rapid development of tolerance. That is generally seen with this indirectly acting sympathomimetic drugs. Let's talk about more of these drugs. Tyramine. Tyramine is present in certain foods. It can lead to the cheese reaction in patients who are taking MAO inhibitors. Another drug, methylphenidate. Methylphenidate is preferred drug for the treatment of attention deficit hyperkinetic disorder, that is capital ADHD. Next, dexmethylphenidate. It is a D-isomer of methylphenidate, and serdexmethylphenidate is a prodrug of dexmethylphenidate. Both have been recently approved for the treatment of capital ADHD. Viloxazine. Viloxazine is a new drug. It inhibits the reuptake of serotonin, that is 5-HT, and also inhibits the reuptake of noradrenaline. It is also approved for the treatment of capital ADHD. Other drugs approved for the treatment of capital ADHD are amphetamines, atomoxetine, and pimoline. Pimoline has been withdrawn because it is shown and associated with a life-threatening hepatotoxicity. Amphetamines are basically addictive substances, and they can result in tolerance and dependence. And they are basic drugs. So urinary acidification by ammonium chloride is used if their toxicity occurs. Amphetamine addicts, they also use sodium bicarbonate to experience the kick effect. Next drug, modafinil. It is approved for the treatment of narcolepsy, and that is generally used in the shift workers, and that relieves the fatigue. in multiple sclerosis, and also it is used as an add-on drug in obstructive sleep apnea. Solriamfetol is a new drug. It is approved for the treatment of excessive daytime sleepiness, that is in obstructive sleep apnea and also in narcolepsy. It inhibits the reuptake of dopamine and noradrenaline. Last, to wind up this particular session and topic of the day, I want to talk about mixed action sympathomimetics. They enhance the release of noradrenaline, especially similar to indirectly acting sympathomimetics. And they also activate the alpha and the beta receptors directly. That is their qualities. The drugs are ephedrine and pseudoephedrine. They are used as cold remedies for the nasal decongestion, and they're also used for their bronchodilator actions. Ephedrine can be used for the treatment of bronchial asthma. It is a vasopressor of choice in pregnancy. Why? Because of beta-2 mediated vasodilatory action. Does not interfere with the placental circulation. Other drugs like methoxamine, mephenteramine, and selective alpha-1 agonist actually interfere with the placental circulation, and they can compromise the fetal circulation, so we use vasopressor of choice as ephedrine and not any other drug. With this statement, I will wind up today's session, and in the other upcoming session we will be talking about sympatholytic drugs, all the blockers. So till then, thank you, take care, bye-bye.